Good afternoon, everyone, and happy Friday. Welcome to the California Collaborative for Long-Term Services and Supports webinar. Today, we're going to learn more about COVID-19 and the specific impacts on rural California communities. We had taken the opportunity during the pandemic to shift our focus on COVID-19 response, and we did a series of webinars related to the response and some of the issues, and had interactions with legislative and department leadership. And so as part of that, we also provided the opportunity for our membership to look at other webinars for us to host that are on relevant topics and not just only collaborative business. And so we're happy to have the opportunity to have this different webinar format to hear directly from folks about kind of the impact that has happened that is specific to rural communities. And as we'll hear, each of those have their own nuances as well. So we're really excited to have this great panel today to kind of go over what they have seen on the ground and what some potential solutions may be. So looking at that, we've got Vance Taylor from the Office of Access and Functional Needs in the California Governor's Office of Emergency Services. And then we'll hear from the hospital perspective from Peggy Wheeler from the California Hospital Association. And then we'll get down to on the ground local perspective, hearing from Karina Avila from the Aging and Disability Coalition of Lake and Mendocino Counties, Jan Lamucci from Kern County LTSS Coalition, and Brian Snyder from the Community Living Implementation Council of Nevada County. And then we will have time for your question and answers for our great panel today. So we really look forward to hearing from the state perspective, the hospital perspective, and then down at the local level. So hopefully you will have the opportunity to learn something new and to hear from these experts. So I will go ahead and kick us off by handing it over to Vance Taylor to give us the highlights of the state perspective. So please join me in welcoming Vance Taylor.
All right, excellent. Thanks, everybody. And I have to make my standard joke, which is, I know we're competing with Netflix, so thank you for tuning in. I'm Vance Taylor. I'm the chief of the Office of Access and Functional Needs at the Governor's Office of Emergency Services. I'm just going to talk a little bit about the model that we've set up for integrated emergency planning and the way that relates really to what we're doing right now with all these events going on, and what the rural impact is. So we go next slide. I'm really going to focus in on emergency communication, transportation evacuation, and emergency sheltering. So those tend to be the three hotspots. Let's go to the next slide. And I do want to just kind of take a second and define, when we talk about access and functional needs, this is who we're talking about, right? It is a very large swath of individuals. We're talking about developmental, intellectual, and physical disabilities, but also chronic conditions or limited English proficiency, and older adults, and people who are pregnant, and it's a lot of people when you start looking at institutionalized settings or transportation disadvantaged, people experiencing homelessness. And when you add up all those individuals and you put it on a map and you overlay that on top of California, which does 40 million people, you realize we're talking about a significant number of people. And this matters, right? This is not a one-off. Let's go to the next slide. I do think it's important that we have perspective, right? I think to understand where we are now is much better appreciated if you understand where we've been. Historically, I will say that we have, as emergency managers, not always done a great job of being inclusive, right? And that's not to say that people were left out intentionally. It is, however, to say that people plan typically from their own perspective. So most emergency managers, a lot of them are former first responders, right? Former military, law enforcement, and not always individuals who have a lived access or functional need experience. And so the example I gave is when I go places, I go and subconsciously, I carry the perspective of somebody that has used a wheelchair most of his life. And so I enter a room and I'm scanning, without even thinking about it, I'm scanning the room, right? Is there a ramp? Are there stairs? Is there an elevator? Can I fit between the aisles? Can I get under the table? All those things. But if you've never used a wheelchair, chances are you may not be considering those things when you go into that room. And so that's what happened is you had these good people trying to do good things, but they were writing plans and making preparations from their own perspective. And that led to significant gaps and marginalization, which translated, at least in Hurricane Katrina, which put a really bright light on this, into an increase in lives lost, right? That 70% of everyone who perished actually had an access or functional need. And so, let me go to the next slide. Recognizing this disparity and recognizing the way that disasters disproportionately impact and affect people with disabilities, and older adults, anyone with an access or functional need. California decided to lean forward and get ahead of this. And the governor created the Office of Access and Functional Needs and put it within his Office of Emergency Services. And the chief, which is the role that I'm fortunate to, I'm able to carry that banner right now, is appointed by the governor at a senior executive level to be the tip of the spear on identifying what are the needs that our communities have. And once we identify those needs, how do we integrate those needs within the way that we plan, prepare, respond, and recover from all disasters? And I'm very fortunate to have learned and appreciated early on that this doesn't happen in a vacuum. Right, let's go to the next slide. In fact, all of our success is really tied to the partnerships, right? Because at the end of the day, all disasters are local. And at the end of the day, we have this acknowledgement and real understanding that the disaster landscape is bigger than all of us as individuals, right? It's bigger than any one county. It's bigger than the state of California. It's certainly bigger than any community-based organization or NGO, CBO, any one single private entity. And so recognizing that is healthy because it helps us understand that we have to work collectively and in partnership in order to really move the needle in this area. And that really becomes, I think, even truer when you're looking at a rural setting, right? One of the things I appreciate about rural settings is that even though it's rural and people might be spaced out more geographically, there's that sense of community, right? We know who we are. We understand the needs. You have neighbors helping neighbors. And there's a real sense of pride in a very positive way about the fact that we take care of each other. And it's that approach, that partnership, that allows us to really, really be out in front on these issues. And as government, we just try and support that, right? Let's go to the next slide. So emergency communication, we want to make sure that when we're communicating, we're not just thinking about the way that you communicate or the way that I communicate, but that we're thinking about the way everybody communicates. And some people are deaf, and some people are blind, and some people have different communication-related disabilities or intellectual disabilities or language barriers. And so we have to accommodate for that because we have to make sure that life-saving info gets all the way to the end of the road. If we can't inform you about what a disaster is, either because we didn't integrate on our side or because we haven't worked with our partners to make sure that on the telecommunication side you have service in your area, then you're not going to have the info you need to be safe and secure. Let's go to the next slide. Emergency transportation evacuation. We have to be aware, right? Do people know who to call? With local jurisdictions, do we have MOUs in place? In terms of operational expediency, are we moving faster? Right? Are we quicker to meet the need? Then as rural communities, you understand what those needs are. Do you have a gap assessment? And then you roll that up. Right? That needs to go up to the county, up to the state, and then we serve as a backdrop to help you fill those needs. Let's go to the next slide. And finally, emergency sheltering. Just ensuring that there's physical and programmatic access. Because we understand people's needs, we can plan to meet them in a sheltering operation. I want to say that the way that this all has come together throughout 2020 has been really essential to the success that we've had, which is not to say it's been perfect because it hasn't. But there have been successes, and those have come because we've worked hard to charge forward in this way. Last month in particular, it is pretty remarkable, right? We had, of course, COVID, dealing with that. Then we had an extreme heat event. Then we had grid instability, followed by rolling blackouts, followed by a freak lightning storm that didn't have rain, which led to a lot of fire starts, which ramped up to air quality issues up and down the state, and on and on and on and on. And what we're finding is, whether you're in a rural environment or a large metropolitan area, you are going to be impacted in some way, shape, or form by disasters. Nobody is exempt, which means it's incumbent on all of us to prepare, right, to plan, to figure out where are we going to go, how are we going to get there, what resources do we need, and to adopt an approach of community. I always say that we never stand taller than when we bend to lift another. I think rural communities are a fantastic example of that. And so in a lot of ways, I say, keep doing what you're doing. But understand that you don't have to do it on your own. That there are mechanisms in place to provide you with assistance and resources and support, and that we'll pull whatever levers have to be pulled to ensure that people can be safe, secure, independent, and healthy. Also, they can have these services provided in a way that maintains dignity, right? Which we are all entitled to. Real quick, you can just flip through and put the next slide. I just want to show you that there's some resources that informationally you can access from our website. And the last one just says thank you. And that's because I thank you for what you do and for getting to spend some time with you today. So thanks.
Great, thank you so much. And those slides will be made available so folks can get those resources as well. So hopefully we can stay on. We'll have Q&A at the end, but thank you for all that great information and overview of kind of the process from your perspective. So now we're going to move on to the hospital perspective and what you all have experienced in some of your more rural regions. And we are excited to have Peggy Wheeler here from the California Hospital Association. So Peggy, I will hand it off to you.
Thank you, Athena, and thank you everyone for the invitation and the opportunity to talk with you today a little bit about the work that brings a smile to my face every day. I have been with the California Hospital Association. It'll be 15 years this October. Always the issue manager, as they call it here at CHA, on behalf of our small and rural hospitals. The Hospital Association itself is an advocacy organization representing the 440 plus hospitals throughout the state of California. And I represent the 60 plus hospitals that are designated by the Office of Statewide Health Planning and Development as small and rural. Of those 60 hospitals, 35 of them are what we call critical access hospitals. They have a special federal certification, meaning that they meet certain qualifications. I can describe them as being our most remote, smallest hospitals. In order to meet that certification, they have to have 25 beds or less and be at least 35 miles away from the next nearest acute care facility. So that is just as it sounds. They're small and on their own a lot of the time. I appreciate the opportunity to talk with you always about the tremendous work that our rural hospitals do, but especially now in the time of this global pandemic. You're all aware that when the emergency was declared, the first thing that hospitals were asked to do was to protect their communities by shutting down, I'm trying to say it delicately, shutting down the ways in which we make money. So we had to eliminate elective surgeries, really reduce the amount of non-emergency visits that we were having. And at the same time, many had to increase expense by acquiring the personal protective equipment that their staff would need and making sure that they had adequate staff to deal with an outbreak. All of our hospitals did that without hesitation in order to flatten that curve, including the small and rural hospitals. I think the impact was exacerbated in these smaller communities because these rural hospitals operate on very thin margins as it is. So when you start at a very thin margin, in fact, 40% of rural providers in the country operate in the red. When you start with those very thin margins and then turn off the spigot that brings revenue into a hospital and at the same time increase expense, it was very worrisome. Those early days were filled with very frantic phone calls from leadership at these small hospitals about how are they going to survive. So much appreciation for the support that the state of California and the federal government was able to give to all hospitals, but especially some targeted monies to rural hospitals through the CARES Act that helped sustain them. I think our concern now is the pandemic continues. In fact, up until just a few weeks ago, we were seeing numbers higher than we had seen when we first went into shelter in place in March. Very concerning, having to do with needing to reopen our economy and still having to deal with people who may have felt that because they didn't experience COVID personally, that maybe they were safe. We had counties in March that had not had a single case. Now there is no county in the state of California, even our most rural, remote county of Modoc has had cases of the disease. So we know that this is going to last a long time, but now there's not as much certainty, both at the federal level and at the state level, about how much financial support will continue to come to help the hospitals. So they're challenged with a couple of things. One, they continue to have some staffing issues. You know, you gear up for the emergency, it doesn't come. You can't keep staff on in that way. So that's one concern. Many of the staff that work in the rural hospitals have kids that need to now be educated at home. So a parent has to be home to help with that. And so they find themselves in that very same situation. So we need to deal with that. We have bills being introduced in the legislature that will require that hospitals maintain a certain level of PPE. Some of these bills started with 6 months of PPE needed to be stockpiled in our hospitals. Many of our small rural hospitals don't even have a place where you could keep 6 months of PPE. And it seems like not a reasonable amount to keep on hand, especially since PPE expires. So we're facing a lot of ongoing challenges right now as we continue to fight COVID. If that isn't enough, then fires broke out. And as Vance indicated previously, they were just devastating, unlike anything that we've seen, although I'm afraid that we're getting used to hotter and hotter fires, and fires that move very quickly and are concentrated in our rural communities. And so that caused another challenge. We luckily this time only had one rural hospital that needed to be evacuated in St. Helena, but many of them were impacted nonetheless, even if they didn't get an evacuation order. So when you're already dealing with a population that tends towards being older, sicker, poorer, not having the means to evacuate, may have already had chronic conditions that the smoke only exacerbates. These hospitals have to be ever ready to address those kinds of issues in their community. And they do a fantastic job of that. I think our advocacy position is that in order to maintain that kind of service in these small remote communities, we're going to need additional support the longer the pandemic happens. And at this point, you know, who knows what's going to come next, but you need to be prepared. So that lost revenue is something that we continue to be concerned about. We're concerned about whether we're going to get additional attention from the federal government and the state government as it relates to filling in that gap. These were hospitals, as I said, that had previous financial issues even going into the pandemic. But now we've got to deal with also healthy patients that are afraid to come back and seek care. You know, we said stay away, and that's what they're doing. And now we're trying to convince them that we can offer services in a way that protects their health. Many of the small rural hospitals operate skilled nursing facilities. Some of the critical access hospitals may have anywhere from 6 to 12 acute care beds, but 99 skilled nursing beds. And so those skilled nursing beds in these communities are generally the beds that are always full. So we need to have the kinds of financial support in order to keep those services in these communities. I cannot say how much I admire the way the communities support their facilities. It's similar to what Vance said. Healthcare is local. Everyone knows everyone in these small rural communities, and so they were able to really partner with their hospitals. These are people you see in the grocery store, and so everybody kind of banded together in order to address not only the pandemic, but the fires. And that strong sense of community is what contributes to the strength and resilience of our small rural hospitals. So Athena, I think I'll stop there as a sort of overview of where we are with rural, waiting to see what will happen next, but feeling supported by our communities.
Great, thank you for that. Yeah, I think when we first planned this webinar, there was no discussion about wildfires, so just another thing to add to the list there, but glad to hear that only one hospital so far had to evacuate, so we'll keep an eye on that, and thanks for all your hard work. So we will move now on to the local perspectives. I'm going to hand it off first to Karina Avila, Aging and Disability Coalition of Lake and Mendocino Counties, to talk about their experience in Lake and Mendocino Counties. Looks like there's a little bit of a typo there, but I think we're all California enough familiar to know. So Karina, please take it away.
Oh, hello, sorry I got in a little bit late, and so I just want to say if I get disconnected or something happens, it's because I'm here, on the Hopland Reservation, and unfortunately our internet, service, sometimes it works well, sometimes it's not so well. So again, I'll apologize ahead of time if I get disconnected. So I missed the very beginning, but some of the things that we're experiencing, which I think probably everybody is in most rural areas, is the whole testing thing. What I hear is, if you don't really have symptoms, it's hard to get testing done. It's kind of depending on, whether you're having the fever and I guess what type of symptoms you're having and how exposure is. For example, if you feel like you may have been exposed through, for example, would be a friend of a friend, tested positive, and so you feel like maybe you need to be tested. They're not really doing, testing in that case, is you have to have been close to somebody who has had testing done. Who has had tested positive, who has tested positive. So if you maybe have mild symptoms and you just want to go and be tested because you think maybe you got it from somebody who was exposed to somebody. They're not doing testing, I guess, in those situations, you know, is what I'm hearing. I know there's a lag in the reporting, and I think that's probably kind of everywhere, you know, as well. So there's a lag in the reporting too of, you know, of how many positives and negatives and all that good stuff. What my concern is though, for the elderly, you know, I live in a mobile home park that has 86 spaces, and I'm going to say 35 to 40% are elderly. And I did get out and chat with some of the elderly folks in my mobile home park, and what I get from, you know, the older folks there is they don't know where to go to be tested. They don't have, some of them don't have a way to get there if they want to be tested. And I'm finding there's not much outreach far as the whole COVID goes, you know, in the rural areas. So, you know, that's a biggie for me, because like I said, I have some old folks that live in the mobile home park that I live in, and there's just like, there's not transportation them to get tested. They're not really getting enough information about the whole COVID thing. So yeah, that's a concern, you know, here in Mendo.
Great, thanks, Karina. We'll move on now to Jan Lamucci from Kern County LTSS Coalition. Jan, are you ready to go?
I'm ready. Can you hear me just fine volume?
Yep, thank you.
Okay, great. Thank you for having this. We appreciate that, especially those of us in rural communities. I do want to say I'm the lead for the Kern County LTSS Coalition, but I work at an independent living center of Kern County. I'm the LTSS manager. So I sent out a request to our staff to see what issues we've been seeing or had any issues with regards to COVID. And our CCT transitions coordinator was actually the one who had issues with a couple of consumers. We had one consumers in the very beginning of COVID and being isolated, and this one or two actual consumers of ours live in a senior housing complex. And approximately 2 weeks once the self-isolation began, these residents of a senior housing complex were not receiving their mail. It was being delivered to a common, you know, mail area location there at their complex, and the residents tend to kind of visit, mingle, you know, while they're waiting for the mailman to come and deliver mail. But with COVID coming and happening, a male person, I should say, I don't know if it's a man or woman, refused to deliver the mail in this common area because everyone was gathered there. The person would come in with the mask. These, you know, residents were not masked up. They're just wanting to receive their, you know, monthly checks or their regular daily mail, any documents that were needed. And this was a grave concern because this one in particular consumer contacted our transitions coordinator because of documents that were needed and mail hadn't been, you know, delivered for this 2-week period. So that was a major concern that we had to go back and check with management, even contact that local post office that did the delivery in that area of town to find out what was happening. So what management of the housing complex did was advise all the tenants to wait until after all the mail is delivered before they can come back into that common area, just to ensure safety and the delivery of their mail. So that was the first concern that I was aware of. And now since we've gotten deeper into the self-isolation and all happening, we had, again, with the transitions with the transitions consumer, we had this consumer who had been awarded a home and community-based alternative waiver due to needing nursing to come into the home. The consumer had stage 4 wounds that needed daily care. as of this week, it's now been over 2 months since the initial award date of the waiver, and still no nursing staff has come to change dressings. So the coordinator has been in communications with the consumer and the waiver agency. And once questioned as to, this is a need, a daily need for this consumer, the waiver agency told our staff member that they encouraged the recipients of the awards, waiver awards, to go search out their own caregivers. That was not an, an appropriate or an accepted response. So our transitions coordinator stated that with this pandemic in place, our consumer needs to have access to nursing care, and challenge them. We said that, we're all about having our consumers be more independent on their own, but they're not capable to find their own, nursing staff. They don't know the requirements, credited nursing care, all of the requirements that an agency would know to have for follow-up and wound care by a nurse. So with that said, there's still no nursing staff. What the agency has required of the consumer is to go to our county hospital. And they go there 3 days a week and are taken care of at the county hospital. And then with that, as soon as the healing process is complete, then the consumer can schedule apparently the plastic surgery that's needed to remove the skin and hopefully get that wound sealed up. So that's been a major issue that we've seen compared to the male issue that was resolved. But this nursing care, the individual themselves, they have to get there. Now there's transportation issues, having to get to the county hospital. I don't know where the consumer actually lives in our community, but getting to the county hospital, which is located in Bakersfield, that's an issue. And then the still the lack of the daily need, that nursing need. I'm looking at my notes here and I've kind of lost my place as to the process. But what they're trying to do is get this wound healed. It would be healed quicker, of course, if there was daily changes of the bandages and all, to be able to get that scheduled surgery. But as mentioned earlier, elective surgery is not being done right now. I know I myself, it'll be 4 weeks tomorrow that I had to go into a hospital due to needing an emergency appendectomy. So I was not happy to even be in the hospital amongst COVID patients. I'm in pre-op, and the overflow of ICU patients were in pre-op, which were just, bay beds, next to me. I wanted out of that hospital as soon as possible. So, I experienced it myself. So that's what I have to, share with all of you, because the rural communities really do have a challenge. Even in smaller, even further outside rural communities to Bakersfield, that could be a 2.5 to 3 hour drive into Bakersfield if you need a service provider that's not accessible in your small community. They may even have to cross county lines because the next county over is even closer than going into Bakersfield itself, which would have, the more service providers available. So those are some of the challenges that we've been seeing due to COVID.
Great, thank you so much for the information and the stories that really kind of bring some of the challenges to life. Last but not least, we're going to hear from Brian Snyder with the Community Living Implementation Council of Nevada County. So Brian, thanks for joining us. I will pass it off to you.
Thank you. I'm happy to be here. Can you hear me and see me?
Yep.
Okay, excellent. I'm Freed's Emergency Preparedness Coordinator, and just to give you an overview of what I do is through a grant through PG&E, one of my duties is to deploy Yeti 3000 batteries or reserve hotels for consumers that have life-sustaining medical devices. So I talk with a lot of consumers every day and that are extremely isolated. Some people, say the isolation is it not different than normal living because of they're already isolated. And I had a conversation with my wife, the other day. She was talking about the isolation. And I said, this is what it's like to have a disability. To be isolated, not whether it be isolation due to lack of transportation or isolation due to just, stigma or whatever. I mean, one of the things sometimes just going out, when I go for a walk, people are calling me brave and courageous just for taking a walk. And I'm just so you know, I'm blind and I have hearing loss. So, there's various reasons for people with disabilities to be isolated. And so this, in some ways, I'm hearing a wide spectrum of reasons for, feeling isolated or not isolated or whatever. But most people are feeling very much more isolated, especially those that don't have internet access. Um, uh, Individuals are having trouble getting access to food. One of the things that Freed is doing is partnering with our food bank and Meals on Wheels program to provide food for older adults and people with disabilities that are isolated and have underlying health conditions. So there's an extreme amount of isolation and fear. Like yesterday, I had a conversation with a woman who uses an oxygen concentrator, has had an embolism, and she's extremely scared. And she, I was having a conversation about getting her a battery, and she just started crying, because of the weight of uh, COVID-19. She has a daughter that has underlying health conditions that is at risk for COVID-19, and the fears of the wildfires and the possibility of public safety power shutoffs. And so everybody is, I've had many situations where people either get angry at me for asking them questions about preparing for emergencies, or they cry, or hang up on me. So I've experienced a wide range of emotions related to the world that we're living in now. And just to kind of give you a general overview, COVID-19 has caused an enormous amount of divisiveness politically, and we're experiencing that, in a microcosm in Nevada County. I think you may have heard, because it made national news, our mayor of Nevada City, Renette Sinham, she started, shouting that this is an injustice, to the mandate to wear a mask and to practice social distancing and not have our restaurants be fully operational. And it's embarrassing because it's, this is putting people's lives at risk. And we have, business owners and community members that are using the ADA as, a reason to not wear a mask. And it's, marginalizing and stigmatizing our community even further, because, there's people that are able-bodied that are saying, oh, I'm just going to say I have a disability so I don't have to wear a mask. And then we have groups like the Freedom Angels that are advocating and working, trying to, stop people from wearing masks and allow businesses to fully open and operate normally. And it's really dangerous and destructive. And we've had violence erupt, people spitting on each other for wearing masks. And it's been very tragic and sad in many ways. And I know that each of you are hearing the same stories all over the state. So it's just generally, what I don't understand is I understand having a worldview and informing one's reality around that worldview. What I don't understand is the fact that those that are saying it's infringement on freedom to wear a mask and practice social distancing. I don't understand why people don't question their worldview and say, well, maybe I could be wrong. And if they are wrong, the consequences are death for a lot of people, and or sickness, or chronic sickness. So yeah, we're living in a very precarious time, and it's strange, and people are, their fear and anxiety are at an extreme levels right now, and I hear it every single day. So that's basically it. I didn't. I wish I had more optimistic news, but this is where we're at. So thank you for allowing me to share our experiences.
Thanks, Brian. Yeah, some significant challenges still with controlling behavior, but I think hopefully we will move past all of this sooner rather than later, but appreciate those insights. So as you can hear, there's some pretty specific information, you know, sort of broadly rural challenges. I heard a lot around transportation, a lot around sort of access, you know, getting people, providers there to help, and those sort of go across the spectrum. But then there's also some pretty specific, you know, county specific issues that are not necessarily connected to every single rural community. So some really interesting information. So I'm not sure if Vance, I thought I saw Vance Taylor come back on, but maybe not. I think he had to step away because he had to help with some fire response issues. So we are happy to have him doing that important work at this time, but unfortunately not available for Q&A. But we do have the rest of the panelists here. So Peggy from the Hospital Association, Karina, Jan, and Brian all still on and available. Folks have questions. So I will start it off with a question about sort of thinking through some of the challenges, the extra challenges that the fires have brought to these rural communities at a time when you were already having trouble getting people places, the transportation. Do you have any sort of lessons learned or best practices about how to deal with kind of two crises happening simultaneously and what that's looked like from your perspective? And Peggy, I'll throw it to you first.
Thank you, Athena. You know, I think the sad part of this is that disaster is becoming more the norm than the outlier, that we are better preparing ourselves. I think COVID threw us a little bit of a loop in that evacuation had to be thought about differently. Even how we evacuate people from their homes. You can't just have everyone get on a bus full of people, older people, younger people, all together in that tight space. But if there was a silver lining to COVID happening months before the fires, we had already come to understand how we needed to do those things. And somebody thought about it. I wish Vance was here. I'd give him all the credit for it. But we were challenged with that. And, you know, I'm going to speak again to what I think are the positive things. Brian, I appreciate where you sit with seeing some of the really difficult things for us to understand, but there are so many more positive stories of how people step up in time of crisis to do the right thing. And we're hearing that at the hospital level and at the community level when it comes to neighbors helping neighbors. Hotel industries opening up their hotels in order to have people be able to evacuate and stay socially distant. I cannot wrap my head around what it must feel like to know that you're leaving and may come back to nothing. But people feel supported by the people in their communities, and if they can value, you know, the things that they live with, I think for all of us, then it means that that's what our role should be. If you can't help somebody directly, then give the resources that will be able to help them do what they need to do. We are going to continue with these challenges. I'd like to talk about pre-COVID life and post-COVID life. There will not be a normal again. And I don't mean that in a negative way. I think this is going to teach us new ways to do things, and it's going to be positive. But we have to bring that positivity to it. So
That's great. Thanks, Peggy. Others, I'll go ahead and go down the list. Karina, did you have any sort of best practices or silver linings that have come out of this? Did we lose Karina? All right, let's try Jan.
Whoops. Best practices. We're still working at day to day as to how we best can work through this. Brian probably recognizes my voice and or name because my independent living center also is part of that PSPS program offering the batteries. And as Peggy just mentioned with regards to hotels, with regards to evacuations, I know we had a small fire that came up in July before all the lightning fires started, and these small rural communities may have like a motel that an individual may be able to be evacuated to, but then it's not accessible. So a lot of the points that Vance mentioned that I know Brian, my agency, and the other agencies who are involved in this through CFILC, PG&E, and our separate individual independent living centers that are offering these energy sources and other resources available because of the fires. Sometimes that learning that challenge and how we can make everyone integrated together, not having the at-risk person go to a skilled nursing facility, just the whole process. Pardon me, as Peggy mentioned, some of this is improving what we have in place. And I think that's what I can just add to that comment alone.
That's great. Thanks. And Brian, did you have any thoughts on that?
In terms of best practices, correct?
Yeah, sort of anything, any silver linings or best practices that have come out of having to create a dual pandemic fire response.
I do, well, I want to say something before I go into that in relation to hotels, because I think it should be mentioned. Because the wildfire, the Jones fire last week, a red flag warning happened on Wednesday, I believe. And it alerted me, I'm thinking we're going to have a public safety power shut off on top of everything else. And so I started calling hotels to see what their availability was locally. And there was nothing available because the Red Cross was utilizing hotels for evacuations, and just community members were evacuating hotels to get out of the danger zones. So, I mean, this is a thing about simultaneous crises happening at the same time, which is a serious issue. But in terms of best practices, it's, I think, as she mentioned, it's something that we're learning as we go. I mean, this is undiscovered country in terms of the complexity of needs and the interconnectedness of everything. I think that we're learning about community resiliency, that it has to happen on a local level, and that there are not systems in place in terms for that. Especially, I'll give you an example. One of the issues we talk about is 5 trusted allies as part of the Listos California campaign for personal emergency preparedness. I often ask people if they have 5 trusted allies, and most people say they don't even have one, especially older adults that are isolated in this rural community. So I think the thing that, needs to happen is a massive systemic change in order for us to survive as communities. And I think that if anything positive is going to come out of this is a push for that, to create local resiliency and autonomy and so on. So thank you.
Great, thanks. And I'll just note that Karina had to hop off, but she did say one thing that the Hopland Reservation was able to do is create a COVID-19 relief center and a meals program for members. So kind of stepping up to help folks during that pandemic. So that's great. And then as a comment about some concerns in rural areas, especially about access to N95 masks, facial coverings, not for COVID as much as for the fires as well, and kind of how do you get that? And, I think Peggy mentioned it's hard to find places necessarily to store all of this, and not anticipating sort of a double need necessarily, but thinking through how to be better prepared for those situations going forward. So thank you for that. So I will open it up and see if anybody else has any questions or thoughts for the panelists. You can go ahead and unmute yourself if you would like, or type it into the chat. Anybody have any questions for the panel in these last few minutes? Okay.
Looks like, Athena, it looks like we have somebody with their hand raised.
Oh, okay.
Talmadge. I will go ahead and open your line, Talmadge, and then you can jump in and ask your question. And I do want to highlight, if you have your hand raised and we unmute you, you still have to unmute yourself. And there's a little microphone button on your toolbar. We'll give you a second. Okay, we'll loop back around when you're ready, if you're ready. I do want to just make a point to say that the recording from today's webinar, along with the PowerPoint presentation, will be made available, and we'll get that out to you early next week. Feel free to share widely with constituents that might be interested in the information. Any other questions? Okay. Athena, I'll pass it back to you.
Great, thanks, Maria. Thanks, everybody. I want to thank all of our panelists for providing great information. And as Maria said, we'll make that available through the slides. And we look forward to continued conversations. And thanks for all of your hard work. We really appreciate it. Have a great weekend, everybody.
Thank you.
for having us.
Thank you.
Bye-bye.